Hi, and welcome to the March 2025 issue of IGIE. My name is Phillip G., Section Editor for IGIE's section on Historical Considerations. Freedom is a necessary ingredient to innovation. I recently learned that there's a saying in Russian that your eyes are afraid, but your hands are doing it. No matter how big is the project in front of you, no matter how scary it looks, you just start doing it, and you do not even notice when you're done. In the 1980s, a young surgeon trained in the Soviet Union in an industrial city that was completely closed off to foreigners. Motivated by mentors who saw his potential and realizing that he needed to venture abroad, he sought every possible opportunity for freedom in order to seek new skills and develop new technology. His journey ultimately led him to a new beginning in the United States and to a storied career as a pioneer in endoscopic surgery. We are honored to tell the story of Dr. Sergey Kantsevoy, who is our distinguished guest for the Historical Considerations section of IGIE. Dr. Kantsevoy was trained as a surgeon in the Soviet Union, performing everything from laparoscopic surgery to flexible endoscopy. After the collapse of the Soviet Union, he immigrated to the United States, where he repeated his medical training and ultimately completed his fellowship in gastroenterology at the Johns Hopkins Hospital in Baltimore, Maryland. It was at Johns Hopkins that Dr. Kantsevoy, together with his mentor Dr. Anthony Kalloo, became internationally renowned for their pioneering contributions to natural orifice transluminal endoscopic surgery, or NOTES, and credited with many of the key initial studies in transgastric access, NOTES resection, and endoscopic closure. As a member of the famous Apollo group, it was also during those years that Dr. Kantsevoy developed the field of endoscopic full-thickness resection and played a central role in the development of the endoscopic suturing device. Dr. Kantsevoy is a fellow of the Japanese Society of Gastrointestinal Endoscopy and is a global authority in interventional endoscopy, endoscopic resection, and endoscopic suturing. He is currently professor of medicine and director of the Center for Therapeutic Endoscopy at Mercy Medical Center in Baltimore, Maryland. Dr. Kantsevoy, thank you so much for taking the time to do this interview. It is truly an honor and privilege. Tell us a little bit about your background, your hometown, and your upbringing.
Thank you very much, Philip. This is unbelievably good introduction. I'm not sure that I deserve all of it, but it is very, very nice that you started that project. I can only imagine how much time and effort you put into that. So I was born in the city, which was the third largest city in Russian Federation after Moscow, Leningrad. And the city had a lot of industry, so it was close to foreigners. I did not have any contacts, and I had to learn language on my own. That's why my language was mostly based on the books and self-study which I had to my disposal. But from very beginning, I was interested in speaking as many languages as I could, just never had a chance. So after I finished my medical school, I started to work in the largest hospital in the area. The hospital was so big that in Russia they stopped making those because it was completely unmanageable. It was about 1,500 beds, 29 different departments. And in that hospital, that's where I was trained to do laparoscopy first. And in Russia, at that point, we did not have MRI, we did not have CT scan, we did not have ultrasound. So the only available modality for us to determine staging, if somebody diagnosed with gastric cancer or colon cancer, was laparoscopy. So in Russia, the training was completely different than from United States. You go to the medical school from the high school. So I entered medical school when I was 17 years old. And then medical school lasted 6 years. Year 1 through 5, you do general medical school. And then the 6th year, you do what you are specializing to do. So my 6th year was surgery only. After I finished medical school, then you go on your specialty into internship. Internship lasted 1 year, and after 1 year, you started to work as a practitioner, but you working for 3 years under supervision. although you already consider full physician or full surgeon. And then after this 3 years is over, you on your own, you can do anything you want to do. So because in my hospital there was no other modalities, I had to do a lot of laparoscopy. I like it from the very beginning. It was rigid laparoscopy, and I was doing about 300 to 600 procedures a year because there was so many patients. I was doing laparoscopy not only for surgery. I was doing a lot of laparoscopy for GYN. When, for example, somebody comes and you suspect ectopic pregnancy or ruptured ovarian cyst, or somebody comes with infertility and you are looking how bad is the adhesions inside the peritoneal cavity. I also specialized in all type of flexible endoscopy, which included not only GI tract. I was doing bronchoscopy, rigid and flexible bronchoscopy. I was doing upper endoscopy, colonoscopies, practically everything, you name it, it was done. The system was very different in Russia. In Russia, the gastroenterologist was just internal medicine practitioner, who would not do any procedures. If that practitioner needed somebody to examine stomach, let's say a person has nausea, vomiting, he will send a request for surgeon, and surgeons were people who were doing all the procedures, flexible or rigid ones. So gastroenterologist will request upper endoscopy or colonoscopy, and I, as a surgeon, would do that procedure, send report to gastroenterologist, who will disclose the findings to the patient. That's how it was. So when I came to United States, I saw that everywhere in the world the system worked the same way. So in order for me to do flexible endoscopy or laparoscopy, I need to go again through the surgical training. And that's why I entered internship in surgery in Bronx Lebanon Hospital Center in New York. And it did not take me long to find out that if I finish surgery as a training, then I will never do flexible endoscopy. There will be always gastroenterologists who will do ERCP, endoscopic ultrasound, and other procedures which I like. Yes, I will be doing rigid laparoscopy and everything related to it, but I will have to stop doing flexible endoscopy. So when I came to the United States, I had to decide what to abandon. To abandoning bronchoscopy was easy for me. I knew that pulmonary people will do bronchoscopy, and I never really liked it. I did it because I had to, but I never liked it. So that was easy thing to give up. The second thing to give up was I was fascinated about laparoscopy for treatment of infertility and other conditions like ectopic pregnancy and so forth. But I knew that as a male physician in United States, GYN, it would be too much risk for me because of malpractice and everything. So I gave up that as well. So my choices were between laparoscopy and general surgery and flexible endoscopy and gastroenterology. And that's the time when I decided that I need to switch my residency. I went into internal medicine residency. Dr. Wartovsky, who was professor and director of the program in Washington Hospital Center, offered me position outside of MH. I accepted that position. I finished that program and then was taken to the fellowship in Johns Hopkins Hospital, and that's how I became gastroenterologist, specializing in all these procedures. But it was always my dream to do more than just screening colonoscopy, more than doing diagnostic procedures. And when I was still in Russia, I believe it was a couple years after my medical school, in 1985, I got a book which was written by GYN from Germany. His name was Kurt Zem. And he was a GYN, but once when he was doing laparoscopy, he saw inflamed appendix right next to the area where he was doing his procedure. And he saw that it would be a good idea to remove it, so he cut it out. And then he started to remove ovarian cysts and other stuff through the laparoscope. And he wrote a book, and I happened to get that book. I was very fascinated with that book, and I came to my chief of the division, and I told her that that's what I want to do. She looked at that, and she said, no. She said that laparoscopy is a diagnostic procedure, and in capitalist countries, the only advantage of removing something or doing intervention in the peritoneal cavity through laparoscope is the only advantage is that it eliminates the scars on the abdominal wall. And it's not worth it. We are in socialist country. We are not going to do that. I was working under her supervision, so I could not really say anything in that respect. But when I finished 3 years of observation, I was lucky and I was able to go to the course in Moscow, which was performed by Dr. Kurt Zem. And you actually have a certificate we put of my specialization there. So Kurt Zem trained me and in interventional laparoscopy. And when I came back to my city, I was looking for opportunity to do something like that. So one day I was on call, and in the middle of the night, 17-year-old boy came, which clearly had acute appendicitis. So I took him for laparoscopy, and I removed that through the laparoscope. And it was not easy. We did not really have any instruments or anything. I had to improvise with what I do, like cutting the appendix with polypectomy snare, things like that, and using hot biopsy forceps to cauterize the appendicular artery, and these type of things which I need to do. So in Russia, at that point of time, there was no pagers, there was no cell phones, and there was no even overhead paging in the system. And there was no place assigned for people who are on call. So I removed that appendix in the middle of the night, and then I went to emergency room, and they allowed me to spend night in some patient's shower on some small bed. In the morning, I wake up and I went to check on the patient. So I come to his room and the patient is not there. I literally felt that the hair on my head stood up. And if you never had that feeling, it's a very, very distinctive, strange feeling. You experience it once, you will never forget it. And I have pictures to prove that at that point of my life, I still had some hair. We put those pictures into these articles to prove. My children look at that picture and they did not believe me that it was me. My daughter said that I just download somebody from internet. If you don't believe, I can ask you to justify that. Anyway, so I feel that my hair standing up, and I was thinking that probably there was a complication, maybe bleeding or maybe something else, and nobody could find me in the emergency room. So they took the patient probably for surgery, and I'm standing there trying to understand what should I do next and where to go to find my patient. And right at that moment, the bathroom door opens up, and that boy comes to the room, and he is completely straight, brushing his teeth, and he tells me, when do I go home? And I said, what do you mean? You just had surgery. And he said, well, I have no pain. I have no complaints. Why should I stay here? And it is only 3-4 hours since he had surgery. At that moment, I realized that laparoscopic surgery is not for cosmetic reason. It's completely different intervention, different impact on the patient. As a surgeon, I was removing appendix. And if you see somebody who had open appendectomy, when you cut the muscles of the abdominal wall, even if the skin incision is small, you still have to cut a lot of the muscles of the abdominal wall. So these patients for 3 weeks cannot do any physical activity. They walk around bending forward, holding something against their wound, and they're afraid to sneeze, they're afraid to cough because it causes tremendous pain. Here's that boy standing straight, brushing his teeth, showing no signs of restriction of physical activity. I realized that that's what I want to do. And I actually published that. And this publication was the first laparoscopic appendectomy which was done in Russia. And this publication is still highly cited in Russia as the first procedure of that type of sort. That was the beginning of laparoscopic surgery in Russia. And we have that publication. I was surprised that you were able to find it on internet, a reference to that publication. I did not really check myself, but I'm glad that you found it. I have the original paper somewhere. Difficult to find.
Yeah, no, that's truly it's a very impressive achievement, and it's a testament of your willingness to explore new frontiers, and it's really an amazing story.
How did you find it, Philip? How did you find that paper on internet?
You can find everything on the internet these days.
That is true, but even 30 years ago. But when I came to United States, I spent some time preparing for United States medical licensing examination, and I was doing that in National Library of Medicine. So at that point, it was 1992, and I wanted to see what is the state of laparoscopic surgery in United States. So when I had some relatively free time, I looked for that. And the first thing I found was big editorial, which was written by Dr. John Cameron. John Cameron was a chairman of Department of Surgery at Johns Hopkins Hospital. He was probably one of the most famous surgeons in the United States. He started to do very aggressively Whipple procedures and pancreatic surgery. He is extremely experienced surgeon. At that point, I think that he was a president of the Surgical Society in the United States. So he wrote an editorial in 1992, and that editorial was about laparoscopic cholecystectomy. And he said that laparoscopic cholecystectomy should not be done everywhere. It should be taken with extreme caution, and it should be limited only to the major academical center till we figure it out how to do it properly and so forth. I completely agree with him on that respect. Laparoscopic surgery in the beginning, when they were trying to remove gallbladder, took many, many hours. There was a lot of damage to the bile ducts. And even at the time when I was already working at Hopkins, I was doing an ERCP to repair this type of damage. But nevertheless, the industry saw potential. They invested a lot of money. They developed a lot of new instruments. The training was established, and 5 years later, after that editorial, almost 95% of removal of the gallbladder in the United States was done laparoscopically. That is how quickly that procedure was adopted. And now you know yourself how many of those procedures are done laparoscopically. The surgeons who finish training mostly trained to do it laparoscopically, not openly.
Right, absolutely. This is a huge huge difference to how eventually notes wound up. But anyways, let's shift back towards endoscopy. I'm very interested to know, how did you learn therapeutic endoscopy? Tell us about your first exposures to therapeutic endoscopy. Because if I remember correctly, you have a very interesting story of how you learned ERCP as well.
Yeah. So the hospital where I started my internship, and then they gave me a job to work, had a big division of the general surgery, and they did a lot of procedures for gallbladder, bile ducts, and so forth. And in Russia, there was a lot of gallstones. We had a side viewing endoscope in the hospital, but nobody was doing ERCP in my hospital. It was a difficult procedure, and they did not do it. We did not have sphincterotomy. We did not have extraction basket. We had a catheter to do the diagnostic part of the procedure, but that was it. The first year after my internship, in surgery was over. We had a large number of deaths in the hospital for people who were operated on the stones, gallstones located in the bile duct, impacted into major papilla and things like that. Because we did not have ERCP in the hospital, we did not have endoscopic intervention of bile ducts. Surgeons had to do open surgery and cutting the bile duct or cutting the duodenum and extracting the stone from inside the duodenum. And this procedure carries a huge risk of leakages after procedure, and the patient simply did not survive. The mortality was high, morbidity was high, and there was a desperate need to do something about it to improve it. So I took on that task, and there was no teacher for me to teach me how to do ERCP. I got several papers written by Peter Cotton. I read about it, and then I made a tube out of piece of paper, drove major papilla on that tube, and made a hole in that major papilla. And then I was spending hours sitting there with endoscope. By the way, it was not it was a fiber optic endoscope. So you hold, one hand is occupied by holding the handle of the endoscope, and then you have only one other hand to manipulate the endoscope and catheter and so forth. So I spent hours trying to cannulate that little hole in the tube. And eventually I figure out the way to do it. And it's different from what it is taught everywhere. So I figured out that if I put my endoscope in certain position towards the major papilla, and then I put the catheter, ERCP catheter, on certain lengths out of the endoscope, and then I would just rotate the big wheel up, and the catheter will slide into the major papilla. That was my way of cannulating it. So after I feel comfortable doing that, then I got a first patient. We put the patient onto the X-ray table. I put the endoscope in, and on the first attempt, I got into the major papilla, did injected contrast, everything was fine, and everybody were very happy. The chief of my department saw that, and she had multiple unsuccessful attempts to do ERCP. She saw that, she was extremely relieved. She said, "Great, from now on, you are doing this." So then I started to do, and several of them, maybe 7, 8, maybe even 10 unsuccessful attempts. I continue and finally was able to do that. By the way, we did not do it under moderate sedation. We did not do it under general anesthesia. All we would have a Demerol shot intramuscularly, atropine shot intramuscularly, and then the patient would be just lying there in pain, throwing up, moving, and sometimes it would be 2-3 hours before I gave up, or patient demand that I would stop. But eventually I got better in it, and when I did my first about 100 of successful RCP, I requested to go through the training in Moscow. There was a big institution named after a famous surgeon called Vishnevsky in Moscow, and there was a very experienced physician there. His name is Dr. Professor Katovsky, and he was very experienced in not only RCP but also therapeutic intervention on bile duct. So I requested to specialize there, and I spent months in that place observing him. And he not only taught me, he became my friend, he became my mentor of my PhD dissertation later on. And when I was leaving his place, he gave me the best gift possible. He gifted me sphincterotomy, and he gifted me Dormier basket. Dormier basket did not survive for a long time and eventually got broken. By the way, at that point, there was no extraction catheters. There was no such a thing. So the stones were extracted by Dormier basket, and eventually got banded and did not work. But that sphincterotomy lasted for me for at least 6-7 years. I was using the same sphincterotomy. The wire, the active wire, will get damaged after 4 or 5 procedures. and then I would have to repair it, to melt a new one into it. And after each procedure, we will clean and disinfect sphincterotomy, which is supposed to be a single-use instrument, but for us it was a multiple-use instrument. And I even brought it to United States with me when I came eventually here. Did not use it in United States, did not have any need to use it in the United States.
Do you still have it in your garage?
Somewhere. By the way, at some point I even found even laparoscopic instruments were not available in Russia, so I had to ask people who did it. And recently I found those instruments in my garage. They're all rusty, but just remind me on the time when I had to do instruments for my procedures myself. And then we will have to autoclave, disinfect them, and use it again and again, the same instrument. You may not believe me, but even the rubber gloves, which we used during procedures, were multiple use. So after each procedure, they will wash it, and they will autoclave it, sterilize it, and then you put it on, and it fall apart right on your hands. That's how bad it was back in Russia. By the way, it made a bad joke on me when I started my surgical residency in Bronx. The first day I come there and I'm a surgical resident, I know I will have to do a lot of dressing changes. So I go to the room with supply, and adhesive tape was the most difficult thing to get back in Russia. Here I am, I go to the room and I see that there is a lot of adhesive tape. I thought that, well, I'm lucky. Today is Monday. I have this adhesive tape, and tomorrow probably will be none. So I put some of it into the pocket of my white coat, and I thought that tomorrow there will be no adhesive tape, and everybody will be asking me for a favor to give them that adhesive tape. So Tuesday I come back to work, and there is as much adhesive tape in that room as before. I thought, well, it will not last longer, so I put some more into the pocket. For about 2 weeks, I was walking around with my pocket filled with adhesive tape before I realized that in the United States there will be never shortage of adhesive tape. I get rid of that adhesive tape. Imagine going through the hospital, carry these adhesive tapes in your pockets. That was stupid of me, but that came from Russia. It was less than 2 years since I came from the country where we did not have it. So that's how it was.
Yeah, that's a complete culture shock for you when you came to the U.S. and decided, oh my gosh, there's supplies in the supply room. Single use is actually single use.
Everything was single use, and the endoscope already moved to the current condition where the nurse, where the tech, where anesthesia, everybody can see what you are doing on your screen, and they can help you appropriately. When I was doing ERCP in Russia, I was the only person who was looking into what is going inside the duodenum. Nobody else can do. By the way, when I was in Moscow, Professor Kotovsky got his first EUS device as well. And that's when I get exposed to EUS device. The device was huge, and it was constantly getting broken. And he also got a babyscope, the first babyscope from Olympus, which was also very fragile, did not survive long. But it was all fascinating look for me to see where the medicine abroad comparing to what I had in my disposal.
Yeah, and I'm sure that really influenced your eventual path into endoscopy, into flexible endoscopy, rather than in laparoscopic surgery as well. And it's a very fascinating story. And I think as an experienced laparoscopic surgeon from Russia, you had a very unique perspective on endoscopy, as that was very different than your peers in gastroenterology. Tell me about coming to the U.S. and then about what happened at Johns Hopkins that allowed you and Dr. Kalloo to really kind of to develop the field of natural orifice surgery
Yeah. So what happened is that when I came for my interview to Johns Hopkins Hospital, and I go to the secretary to introduce myself, and there is a young gentleman live in that room, and he said, "Hi, my name is Jay, and I was coming for the first interview, and he was assistant professor, and he was leaving, and I did not realize first." But then I find out that that was Jay Pashricha. He told me his last name. And by then I already knew about Jay Pashricha. I read about the botulinum toxin, which he invented for treatment of achalasia. I thought that Jay Pashricha would be 60, 70-year-old person. Instead, this was young guy who was very brilliant. You can speak with him for 5 minutes to understand how brilliant he was. And he already, before he even came to fellowship for Hopkins, he finished his fellowship in pulmonary, but then he decided that he wants to do GI. So at that point, when I was coming for interview, he was leaving to Galveston, Texas, where he became the chairman of the Department of Gastroenterology, and practically he did it from nothing. He created one of the most productive GI divisions in the country. He enrolled very successful people, Dr. Raju and Dr. Kutani. I think even Dr. Waxman was one of his first recruitment there. So Jay started his new career and as an administrator, and he was very successful in that one as well. And that was the quality of the people whom I met at Johns Hopkins. So the next person whom I saw that day was Tony Kalloo. And Tony was doing ERCP, so they gave me my folder and they said, "Can you go to endoscopy to talk to him? He will interview you in between cases. He is extremely busy." So yes, I went there, and he had very few minutes. He came out and he started asking me, and then he asked me, "Do you have any problem doing experiments on animals, pigs, dogs, and so forth?" I said, "No, I don't have any problem. I'm happy to do that." And he said, "You are exactly the person I was looking for." And he strongly supported my candidacy for fellowship. And another very strong supporter was Professor Wartovsky, who is the chairman of my residency program in Washington Hospital Center. Professor Wartovsky was actually in military, and he was chairman of Walter Reed, but after spending 25 or so years there, he moved to Washington Hospital Center. And Professor Wartovsky was convinced that I belong to fellowship in a good institution. So he personally called to several people whom he knew as a faculty at Hopkins and convinced them to support me. And so with his help, with help from Tony, I got enrolled into Johns Hopkins Fellowship. And during my second year in the fellowship, Tony Kalloo, Jay Pashricha, Peter Cotton, Rob Hoss, Sidney Chang from Hong Kong, and Chris Gastout created Apollo Group. At that point, Olympus was looking for new ideas for interventional endoscopy, and they got most talented gastroenterologists around the world together in sponsored the first meeting to see what kind of direction of interventional endoscopy can do. And Tony took me as a fellow to that meeting, the first meeting when Apollo Group was formed. So each member of the Apollo Group has their own project in mind. Chris Gastout, for example, wanted to do a widespread mucosectomy to remove Barrett's esophagus. Please don't forget, it was 1998. So at that point, ESD was not even born, and all we had a piecemeal resection, and he had idea that if there is a device, then we can resect the entire mucosa. So Jay Pashricha wanted a device for endoscopic correction of gastroesophageal reflux disease. Peter Cotton, Rob Hoss had their own ideas, and Tony Kalloo wanted to remove the gallbladder through the natural orifice entering the peritoneal cavity through the mouth, through the wall of the stomach, and then to remove the gallbladder. So we discussed it all with Olympus, and Olympus engineer said that, okay, we will work on some of those ideas, and let's meet again in 6 months. So we went back home, and I started to do experiments. So I took a side viewing endoscope, put it inside the stomach, cut the wall in the stomach, and went into the peritoneal cavity without any damage. Tony was at that point doing the RCP, so I called for him. He came, he confirmed that there was no damage to the wall of the GI tract. Then we did a couple biopsies, and then we closed the gastric wall incision with the clips. It was acute experiments. We did not intend to survive that animal. So it was important to do that experiment acutely, because we needed to open up the animal to make sure that not only through the endoscope we did not damage it, but we really did not damage anything in the peritoneal cavity. So the autopsy confirmed, and after that, that is how the transgastric surgery, how we called it, transgastric surgery, was born. I did several more experiments, and then we presented that during the plenary session of the DDW, and eventually made a publication as well after we performed some more experiments. And this publication was the origin of the notes in the world. It was not called notes at that point. We called it transgastric surgery. But the funny portion of it is that 6 months later, when we met with Olympus, each of us presented our project, what we did so far, and Olympus assigned engineers to each of the idea which we raised on the first meeting. So after physician would say, let's say after Chris Gastaut would tell about his experiment, then Olympus engineer will show the prototype of the device which they foresee for the widespread EMR. And Jay Pashrichi will talk about what he did for the correction of GRD, and Olympus will show the prototype device which will be used to correct GRD. And then I came to the podium, and I told about my experiments and about the success of entering peritoneal cavity. And then Olympus engineer who was assigned to that project come to the podium with his slides, and he wrote his talk in advance. So Olympus took a position, and he showed that it's impossible to enter peritoneal cavity without damage blood vessels, without damage adjacent organs, and so forth. So I was shocked. The discrepancy between how we see that and how the engineers see that. So he did not change his presentation. If I were him, I would just change it, because we already proved what it is. But my idea was not to remove the gallbladder through. I never really thought that notes should aim at the removal of the gallbladder, because as a surgeon, I know how dangerous that situation is, and you have to have a precise view. And Dr. Cameron was absolutely right when he was saying about caution operating through the laparoscope in that area, because the damage to the bile duct is very easy to perform. So, and I never wanted to remove a gallbladder through the stomach, because you are doing it in unfavorable position, in retroflex view, and flexible endoscope is not stable inside the peritoneal cavity. The biopsy channel is too small to stop major bleeding from the arteries. So for all this reason, my ideas of nodes was very different than removal of the gallbladder. I thought that the nodes should be entering peritoneal cavity, do something in full thickness resection, remove the organ which is not as dangerous as gallbladder, maybe appendix or maybe something else. And then the most important part, in my view, was to develop a suturing device. Actually, the whole project, I was interested in NODES project to get a suturing, reliable endoscopic suturing device. So Unfortunately, when I was talking preliminary about the suturing device, nobody wanted to put any money into it. Industry did not want it to do with that. And when we come up with that project, which became nodes, the industry got extremely excited, and they were afraid that it will be the same story as with laparoscopic surgery. Few companies like Ethicon and US Surgery believed into laparoscopic surgery. They put money into development of devices for laparoscopic surgery, and they practically owned the market of the laparoscopic surgery instruments, so they got profitable. The company who came late to that development did not really benefited from laparoscopic cholecystectomy or other laparoscopic procedures. So when the node was formed, all these companies which did not participate in laparoscopic development wanted to be part of it, and that is how they came on board. But the suturing device development was not that simple. When I told about that experiments and I said that we need a reliable suturing device, then engineers from Olympus asked me, what would be clinical application for that suturing device? I said one application will be to close the incision after transgastric entrance into the peritoneal cavity. Another application will be to close bleeding ulcer. By the way, Sidney Chang from Hong Kong was working in the hospital where they have a lot of bleeding. He did a lot of original research of bleeding, GI bleeding, and he is actually one of the rare surgeons who is doing a lot of flexible endoscopy. So Sidney Chang was extremely interested in the suturing device to close the bleeding from the bleeding duodenal or gastric ulcer. So he was very well equipped to do that. So I said another application will be to develop anastomosis between the organs and so forth. So I named them 6-7 applications, and they said, okay, we will think about it. So next time when we meet in 6 months, Olympus said that we are not interested in developing the endoscopic suturing device. I said, why? They said, well, there is no way that we can sell 6 different suturing devices. I was surprised saying, why 6 devices? They said, well, one device to close the incision after entering peritoneal cavity, another device to suture the bleeding ulcer, another device to create anastomosis. So in their view, there were 6 different modifications of the device for one device for one application. I was stunned by this. To me, it was just one device to do all these tasks. But later on, when I got older and I probably got a little smarter, I realized that Olympus was operating from different perspective. Olympus, if they, let's say, come up with a suturing device, and if they brought that suturing device to Food and Drug Administration, Food and Drug Administration will approve one device for one application. And then, if you are starting to use that device for different application, that you are working off the indications. And Olympus, as a company maker of the device, cannot encourage that. So Olympus was right from that point, that they would have to apply for FDA with application for each task. And that probably will require some modification or something else. They cannot just get permission from FDA to get a suturing device to close, let's say, defect after removal of the big polyp, and then encourage physician to use the same device to suture perforation. Mm-hmm. So from that point of view, I understand why Olympus was hesitant to develop suturing device. But we, as a physician, we got very frustrated. Olympus eventually developed some prototypes, but these prototypes was very cumbersome. It could only do separate stitches. You cannot do continuous suturing. And after you making each stitch, you have to pull the device out, and then you put a new cartridge to go back in and do it. That device was called Eagle Claw. That was the term created by Sidney Chang, because it looked like a foot of the eagle when it was manipulated. Mm-hmm. But I still have a couple of those prototypes in my lab, and I don't think that it exists in any other form. But that eagle claw was a grandfather of the overstitch endoscopic suturing device. So Olympus never put resources to improve the eagle claw to the point that it would be clinically acceptable. And we got very frustrated moving to nowhere. So we, as Apollo members, we put our own money and we created Apollo Endosurgery. And several years later, Apollo Endosurgery created a decent first version of the overstitch, and that was a cumbersome. It was very expensive. I still have several of those devices, hoping that at some point there will be a museum or something which will help, and people will be interested to see different generation of the suturing devices. And then after the first modification was available, then Apollo improved it, and we have a now currently available overstitch.
Yeah, no, it's truly a very fascinating story of how you guys decided to create Apollo Endosurgery. Tell me a little bit more about how you guys formed the company and how Apollo then took off and was able to take this idea to completion, actually, because I know, Olympus did a lot of the groundwork in creating the eagle claw, but then, what happened between the creation of the company and the first commercial launch of the overstitch?
So we had multiple patents for the suturing device. Me and Tony are co-authors of the multiple patents, and because we were working at Johns Hopkins, then Johns Hopkins also co-owned those patents. And so when in 2006 or 2005, there was a first meeting of the NOSCAR Consortium. And at that meeting, there was a decision to create nodes, and the term of the nodes was created, natural orifice transluminal endoscopic surgery. And while we came for that meeting, all of us from Apollo Group, Jay Pashricha introduced us to Dennis Williams. Dennis Williams was an entrepreneur who was interested in creating this startup. So we interviewed Dennis, and we saw that Dennis possess skills and knowledge to do that company. And that's how we formed Apollo Endosurgery. So we put our own money. The universities where all the members of Apollo Group were working become co-founders. And for example, Hopkins contributed those patents, given license for Apollo to use our patents for the suturing devices. And Dennis also had connection with investment world, so he got some investments. And initial Apollo was started in Austin, Texas. Unfortunately, soon afterwards, that crisis happened in 2008, where everything collapsed, economy collapsed, and Apollo was almost crushed. But Dennis was able to figure out arrangement with another company where Apollo got investment from them, and Apollo started to also acquiring the balloons. So Apollo kind of moved themselves into more obesity company rather than nodes company. And from one point of view, it was beneficial because it helped to survive for Apollo. But then from the other point, Apollo had to waste resources for intragastric balloon, lab band, and all this stuff, which was distracting from the suturing device. So we went through several rounds of financing, and finally in 2016, Apollo went public. And a few years later, Apollo was acquired by the Boston Scientific, and it's now part of the Boston Scientific.
Very interesting. And those years, I think sort of you referenced 2008 or the late 2000s. I feel like something kind of happened during those years. When we look at all the notes work that you did by yourself and Dr. Kalloo and others, really sort of the early to mid 2000s were really the golden years of notes research. You guys were taking out spleens, taking out all sorts of other organs using notes methods. But then, and that led to a lot of the advancements in endoscopy today, which we now consider to be the legacy of notes, stuff like POEM and ESD, etc. But then in the late 2000s, I feel like stuff just kind of happened, which then brought about the end of this traditional idea of notes. What happened exactly? I think this is, later generations, like my generation and beyond, they don't quite understand this historical aspect in terms of what happened.
Yeah, I think you raise a very good point. So at that point, when we started transgastric surgery, people got very excited. For example, Chris Thompson was one of the earliest adopter of that technique. He was still finishing his fellowship when he saw these first experiments in notes, and he started to do that as well. And that has eventually got his interest in bariatric endoscopy and other procedures. And besides Chris, there were many, many surgeons and gastroenterologists who were extremely interested in notes. But what happened, notes consortium got big investments from the companies, device manufacturers. There was a lot of money. Unfortunately, among the people who were in notes group, many of them decided that nodes should follow the pattern of the laparoscopic surgery. So they aim at removal of the gallbladder. I was not a fan of it. I was actually very much against it, seeing how many complications were in the beginning of the laparoscopic surgery. But at that point, society accepted it. And I knew that society will not accept if we will go and try to remove the gallbladder through the stomach and then create again this number of complications. The whole project will be stopped. The strong supporter of my idea, also thinking the same way, was Jay Pasricha. Both of us, we were completely against this nodes removal of the gallbladder. And Jay actually come up with a very bright idea of doing a tunnel in the esophagus and correcting achalasia. Achalasia was his old enemy, and he fights with achalasia with the botulinum, which turned out to be only temporary solution. So he was thinking for a better solution, and that is how he come up with the idea of the poem, which was not called poem at that point. So he wrote a big paper, and Dr. Inouye saw that paper, and Dr. Inouye started to do a clinical job. So he was a true inventor of the poem in humans. Jay was true inventor of the poem as a concept and animal justification of the poem. So nodes did not die. Nodes gave a raise to the third space endoscopy, and poem is a very successful application of the third space endoscopy. But unfortunately, most of the people in the nodes consortium were kind of fascinated with the idea of the removal of the gallbladder through the natural orifice. And they put a lot of effort into it. And because from the stomach you do it in retroflex, it was not a good idea. So they come up with transvaginal approach, which gave you a straight shot to the gallbladder. Unfortunately, the history demonstrated that transvaginal approach, that is how actually laparoscopy started. Laparoscopy started as a colposcopy when they were putting patient into the knee-elbow position and then going through vagina into the peritoneal cavity to examine the peritoneal cavity. But that did not last for a long time because position is very uncomfortable. Plus, you cannot do it in men. So even if they developed transvaginal cholecystectomy, it would not be applicable for half of the population. So they were trying to do that transvaginal cholecystectomy, transvaginal removal of the appendix and things like that. And eventually they come up, they spend most of the notes money on the trial comparing traditional laparoscopic cholecystectomy and transvaginal cholecystectomy, hoping that it will show non-inferiority of the transvaginal appendectomy, transvaginal cholecystectomy. But that is obviously not the purpose of it. And after all the money was spent and they did not show any advantages of transvaginal approach over the traditional laparoscopic approach, that is where the enthusiasm for this type of procedures was gone. To me, it was just a proof that from very beginning, I was thinking that way, that nodes is not about removing the gallbladder. Somehow, most of the people thought that nodes is about removal of the gallbladder through the natural orifice. Yes, I agree with you 100%. That concept is dead by now. Maybe in the future, when they will create the endoscope with variable resistance, which you can lock inside the peritoneal cavity, make it stable, create a big accessory channel, maybe that idea will be again re-examined. But right now, nodes as a version of the transvaginal or transgastric cholecystectomy definitely abandoned. But nodes itself, in my opinion, is not abandoned. My opinion of nodes is that you have a lesion in the stomach or other parts of GI tract which goes into the peritoneal cavity, and for some reason, let's say there is adhesions from previous attempt or other reasons, or position is difficult, you cannot remove it within the third space. Then you remove it full thickness, and if necessary, and then after that you close the incision, and through the natural orifice you perform the nodes procedure. And I do appendectomy through the colonoscope. Of course, it will not be helpful to do appendectomy for somebody who has acute appendicitis, because appendix is very inflamed. You cannot invaginate it into the cecum. But my idea is that if somebody has recurrent appendicitis, and then you will use antibiotics, you transfer it from the acute appendicitis to the chronic, and then when the appendix is not inflamed, you can go through colonoscope and remove it to prevent the next episode of appendicitis. Mm-hmm. And similarly, you can do it in GYN, you can do it in other parts, but the gallbladder is not the right idea through the natural orifice, and that is what slowed development of the nodes, and that is kind of diverted nodes from the way that we thought it would be.
Like, in other words, I feel like from your perspective, the major legacy of nodes really, or the whole point of nodes, was actually the suturing device.
You're absolutely right. Suturing device changed my life, and that's what I expected to happen. And suturing device changed life of many, many people. Now people who finish their fellowship in GI have exposure to the suturing device. And for example, in my unit, if somebody has accidental perforation of the stomach, let's say for different reason, or perforation of the colon during screening, colonoscopy or otherwise, we are not sending patient for surgery. We repair it through the colonoscope or through the upper endoscope, and we are doing that for surgery as well. When I came to Mercy, surgeons were my best friends, because if I had any complication, they would come and help me. Now the situation is completely different, because if we have a surgical anastomotic dehiscence or any other problem, then we can just repair it through the endoscope with the same suturing device, which doesn't require 6 different versions. The same suturing device can do that. By the way, I am still think that the suturing device made a huge progress. And it's also bring together surgeons and gastroenterologists, because surgeons also started to use that device.
And I think for surgeons, and I think because of your background as a surgeon, it just feels very natural. I think surgery, there's a concept of taking full thickness sutures to close, whether it's to close defects, whether it's to create anastomoses. These are all very familiar concepts to surgeons, which I think with you being sort of like the in between kind of pioneer, you were arguably in the best position possible to embrace that concept.
Yeah, I think that all my previous experience in Russia kind of led to that.
Yeah.
But even if you are a gastroenterologist with some additional training, to use of surgical of the suturing device is very simple. And when we were working with Apollo, I was telling them that what I want a device which will be easily manageable by the person who operates on it. For example, even the biopsy forceps, which is a simple device, you're entirely at mercy of your assistant. You will tell them when to open and you will tell them when to close. And if, let's say, they close it too slowly, then peristaltis can move the lesion which you are trying to biopsy away, and then you missed it. So I wanted from Apollo that I would be all in charge of that suturing device. And you can see yourself, you can open it when you want to, you can close it when you want to, and you only need any assistance when they are cinching it. But the truth is that if I get a new technician who is not familiar with that, I could just put the scope down and I put a cinch myself and I can cinch it as well. So the surgical suturing device overstitch in its current version is an extremely friendly device, and you don't really need well-trained assistant to manipulate it. You do it yourself.
Yeah, absolutely. What happened to Apollo? I mean, the company obviously became Boston Scientific, but what happened to the group?
So the group actively participated in development of those different projects, but then, for example, Olympus come up with the device for correction of gastroesophageal reflux disease, and then there is a DDW, and suddenly I see the Endio device was presented. So I knew that that device is far superior than the one which we were developing in with Olympus. So that project kind of went away. And then widespread mucosectomy became obsolete because the ESD came to the market, and the ESD obviously give you much more opportunity than widespread mucosectomy. So several of the projects went away, and Apollo Group also Olympus had some legal issues with the company, and they become very conservative. So they did not wanted to do any new aggressive endeavors, and that is why Apollo eventually stopped being very active. It is, and most of the members of Apollo Group has now stopped clinical practice. I think me and Jay Pashricha are the only people who continue to do it. By the way, Sidney Chang was very active, but then the epidemics of SARS happened in China and then Hong Kong, and Cindy had to go to the Papua New Guinea. Was very difficult to get in touch with him, and last time I saw him just a few years ago when he briefly visited United States, we had kind of reunion of Apollo Group at Johns Hopkins. Tony arranged that, but that's what it was. And when the NOTES project was still active, I got interested in another project. I started to do intravascular intervention under ultrasound guidance. Once I read a paper by Bill Brugge and Kai Mattis, and they injected a solution under ultrasound guidance into the blood vessel. I got very excited with that idea. And so we started to perform a series of experiments, and we did measurements of the portal pressure. We put a catheter into the portal vein and then trying to do ERCP on the pig, and we discovered that there is a connection between the bile ducts and portal pressure. When you injected contrast into the bile duct, suddenly the portal pressure went up. And nobody knows really about this thing, but it may be important in people with portal hypertension. And I also did a splenic vein occlusion through the ultrasound guidance. So we did all these experiments with Cook, And later on, when I moved to Mercy Hospital, we did those experiments in 2004 to 2008. We published a lot of publications, including the first placement of the tips under the ultrasound guidance. So then I moved to Mercy Hospital, and unfortunately, Mercy Hospital did not have its own animal lab. And I was trying to rent animal lab outside, and it was extremely expensive. So I stopped doing experiments on live animals, which was needed to do all this portal pressure measurement and so forth. And that area kind of was quiet for a long time, but now it has a second rebirth when Cook finally made out of our experiments, they made a device to measure blood, to measure portal pressure directly, not indirectly, but directly, portal pressure measurements. And that device is clinically available and practically everywhere people using it. And also, they created a new field. They called it endohepatology, and Marvin Drew and in Boston is actively working in that area. So that is a new field, and it is somehow related. I guess that through me, it is related to nodes too. So it is a cousin of the nodes eventually.
Right.
Look at that. So if you will think that I'm a grandfather, then this is the both nodes and the hepatology related in a way.
It's like to some degree, it's like we're all related, right?
Yeah.
But you bring up a very interesting. You brought up some very interesting points, and I think it's worth discussing. The role of industry and what you've learned over the years from working with industry, protecting your ideas, and not just the role of industry, but also the role of your own institution and potentially hurdles within your own institution when it comes to innovation and new devices.
Yeah, that is a very important point, which we did not know when we started all this. So we completely depended on the institution. And for institution, they made a lot of patents, but then they are having their own priorities. They are not really interested in developing certain things, and you are not in the top of the list of the institutional priorities. That's how we had to go outside to create Apollo for our project. But I think that the most important, and that was the part of it, whatever we create in Johns Hopkins, it belonged to Johns Hopkins. And if Johns Hopkins doesn't want to develop it further, then that's it, the project stops. So that was part of the reason why I moved to Mercy Hospital. Mercy Hospital allowed me to do any individual science, and they don't claim anything on the intellectual property which will be created by me on my free time. And also Mercy process of, let's say, getting stuff through the institutional review board is much shorter. It's prohibitively long and prohibitively difficult to participate in some multi-center study if you are working in a big institution, big academic institution, where the IRB may require 6 to 9 months before your project is approved. By the time your project is approved, the other institution who were your partners already finish enrollment, and you are behind, so it is not worth it. But the most importantly, what I learned, that you have to defend your intellectual properties. Mm-hmm. When we were working, the industry definitely needs physicians for guidance, for advices, but physicians has to have something out of these advices. It cannot be that you give idea to the company create a product, and then sell that product, and you get nothing out of it. And there are numerous examples of that in the past, where, for example, Dr. Guinan or Dr. Cotton will create a stand, and the industry give them name of the stand, but they will not benefit anyway financially from that. And I think that physicians should be part of this process. They should benefit from the ideas which they give to the industry. By the way, I forget to mention my first meeting with Peter Cotton. As I said, that I was reading about Peter Cotton papers when I was back in Russia. So I thought that by the time that I came to United States, by the time that we first meet in as Apollo Group, Peter Cotton will be 100 years old, very old and so forth. And suddenly our first meeting of the Apollo Group was arranged in South Carolina. And then I entered the same room, and here is Peter Cotton, and he is pretty much alive. He is not even old. And I never guessed that I will be in the same room, breathing the same air, talking to the famous legend Peter Cotton. Really, I did not think that that will happen in my lifetime, but it did happen. I was surprised.
Yeah, I think a lot of us who have met Peter Cotton feel the same way about this experience as well. Do you think there's a future for notes? I think you kind of talked about this a little bit, but obviously there's a future for notes as it is right now in terms of endoscopic resection, in terms of POEM. But do you think there's a future for notes in terms of like intraperitoneal work?
Yes, I definitely think that there will be a future for notes. But the question is that with currently available flexible endoscopes, it is extremely difficult and even very dangerous to manipulate inside the peritoneal cavity. You need to have endoscope which have ability to rigidize. And there were some early version of it when notes was in full-blown development. But then eventually the company who manufacture devices, they have a relatively short cycle. They need to get return on their investments quickly. Right. And that was not happening. But unfortunately, that stopped development of the nodes. And again, the funds were directed in the wrong field. And that is why no new investment was happening into that field. But I do think that we probably don't know it, but with invention of robotics devices, which have that ability to rigidize in the middle of it, it may be rethinking the development of the nodes. And currently, robotic surgery is actively going into the peritoneal cavity.
Right.
It may not be the gallbladder and bile duct intervention, but some of the intervention will definitely benefit if it is done through the natural orifice. The other problem is that when there was a huge difference in invasiveness when you go from open surgery to laparoscopic surgery.
Right,
if you don't cut abdominal wall, level of invasiveness goes down dramatically. But the level of invasiveness, when you compare going through the laparoscopic puncture and natural orifice, the level of invasiveness is much less. The difference in level of invasiveness is much less comparing to the open surgery and laparoscopic surgery. So we gain something, but it is not enough to justify investment into the technique from the point of the laparoscopic manufacturer to spend more money into that. Eventually, I think that society will get to that point that it will be doing it, and then it will be accepted. And I think actually the good thing happened to us very recently. People did not realize it, but for example, Chris Thompson developed the whole field of bariatric endoscopy. But from very beginning, when the bariatric endoscopy started, I suspected that will be time of the life when they will finish treatment, they will develop a reliable drug for treatment of hepatitis C. They will eliminate hepatitis C. And then the industry will start looking how to eliminate the fatty liver, steatohepatitis,
right.
And they will come up with the pill which will decrease the appetite and which will be very effective in the weight loss. So right. What we were trying to do out of desperation, we had a lot of people who were morbidly obese and people who did bariatric endoscopy trying to decrease their morbidity, decrease their mortality. And the only thing we had was either surgery or less aggressive endoscopic intervention, right?
Right.
But now there is a different story. Now there are very successful drugs which can achieve significant weight loss. And after this is achieved, people who are doing currently bariatric intervention will be free to experiment in different direction, right? Because the need for bariatric surgery and bariatric endoscopy is not as big right now. I know personally bariatric surgeons who lost about 20-25% of their volume because of this the medicine like Majoria and Ozempic and so forth.
Absolutely.
So these people have more time to devote effort to unmet areas. Right. And the company which previously specialized on that, let's say company which manufactured intragastric balloons, now no longer need to spend time on that. Company which manufacturing laparoscopic band doesn't need to spend effort on that. So those companies may start making effort in developing devices for the nodes.
Mm-hmm. Absolutely.
I think that's the next
the future.
direction.
Right,
next direction, which your generation will probably have to take over and carry.
No, we certainly have big shoes to fill in terms of looking up to mentors and pioneers like yourself. Brings me to a slightly different topic, which I think is equally relevant and equally important, and that is let's talk about you and the people that inspired you. Who do you count as your mentors and teachers, and who inspired you to become a successful pioneer and physician?
I have a lot of people who made a huge impact in my life. And one of the first people was Nikolai Borisovich Sharapov. He is a prominent surgeon. He is a chief of Department of Surgery in the place where I came for internship. So the first day I came to internship, and he took me as a second assistant on the surgery, and he opened up the stomach, put his hand into the stomach, and he said, "That's it, Whipple procedure." And I heard about Whipple procedure, but I never saw that the first procedure which I will participate will be Whipple procedure. And it was so rare. There were just 2 people in the whole institution who were doing that. And each time it will be discussed for days what they will do and so forth. And here he is, open the stomach and Whipple procedure. And there was no mechanical anastomosis. Everything was hand sewn. So it was 5-6 hours. I was going there thinking it will be 1 hour procedure, 2 hour procedure. Instead, I'm there for 6 hours. And he is doing it, and he was successful in doing it. So this person taught me a lot of things, including life kind of things. In Russia, at that point, the diagnosis of cancer was a death sentence. So we, as a physicians, were not allowed to tell the patient that he or she has a cancer. So if somebody had cancer, you will have to tell them, oh, you have inflammation, or you have this and that. So that because the thought was that you're telling them that practically that it is death sentence and we cannot help you. So one day I'm doing round with Dr. Sharapov, and we get into the room, and there is a patient, and I know that the patient diagnosed with gastric cancer. So I present the patient to the physician, and he said that you need surgery. We need to remove your stomach to help you. And the patient refused, said, no, I don't want surgery. And I started to convince him. And Dr. Sharapov was waiting for a few minutes, and then he just stepped out of the room. I was trying to convince him more, and finally we finished conversation. I step out, and he is waiting for me there. And he said to me, Sergey, I never try to convince people to have surgery or any other procedure. He said that patient knows themselves, and if they are not willing to do that procedure, then if there is any complication, they are not ready, they will not fight, they will die. So I give them the choices, but if the patient doesn't accept it, then I'm not trying to sway them one way or another. I think that left an impact for life on me, and I try to follow his steps. So if I see somebody, I present the objective picture. I tell them what we can do for them. What could be the benefit, what could be the risk, but I will not try to convince patient to go one way or another. I think that it's their body, and that's one of the very valuable lessons which I learned when I was only 23, 24 years old, and it stays with me for the rest of my life. Another good example he gave me was that he was a very active chess player. So he will run through his day very quickly with intent that at 3 p.m. in his office, he will pull out the chess and people will come and then they will play and play and play. They will forget about the time. Finally, at 6, 7, 8 o'clock, the wives will start calling, demanding that they drop whatever they're doing and come back home right now, and that's when the chess will stop. So at some point, they arranged the chess tournament in the hospital, and all surgeons were participating. I was a good player myself. He was a good player, but nevertheless, he lost me. And then suddenly, I see that he stopped taking me to the operating room. I realized that it was just a petty retaliation. And I look around, and he was a chief of department of surgery. But there was a chairman of the entire department. He was also a very good chess player. And I knew that because I played with him more than once. And suddenly I look at it and I see that he is such a good chess player, but he is in the bottom. He is losing everybody. And then I realized that this is a calculated move. He is trying to do that in order not to have enemies. So I learned the lesson from these two people. I quickly gave up all the rest of the competition. I finished, on par on that other professor in the bottom. And then I started to go back to the operating room. So I learned my lesson. What is more important, to be a chess champion or to continue my residency unimpacted? So that's what it is. So one day, I was doing research in that hospital, and I came on Sunday. I'm sitting in this room where all the physicians are looking through the chart, and suddenly he comes. Dr. Sharapov comes to the room. He looked at me and he said, "Why are you sitting here?" And I thought that he meant why I'm sitting here on Sunday. I said, "Well, I'm doing research, looking through the chart." He said, "No, that's not what I mean." He said, "What I mean, why are you still in Russia? You have to go out of Russia. You have to move on into the world." So I did not think of myself that way, but he obviously saw some potential, and he saw that I overgrown what I can achieve in Russia, and I should go and try to see if I can survive in the real world, not in the town. Maybe it is even sold in Russian Federation, but it's not big enough to accommodate what could be done. So I'm thankful for him for that push. But the other reason why I left Russia was that I had a second scientific advisor on my PhD. The one advisor was Dr. Kotovsky, which I mentioned earlier. But second one was Professor Gagushin, the one who gave up all his chess during the chess tournament. So Professor Gagushin was a very prominent surgeon, very smart guy, and he saved many, many people in that area. But once in the middle of the Russian winter, and it was in 1992, in the middle of the Russian winter, he went to the small town where his daughter lived. And then in the morning, he was found dead in a deep excavation outside of this small town. And his death was never really investigated fully. They never found why he ended up there. And it was very far from her house. And how did he end up there? So his death was not properly investigated. At that point, I realized that the life of the person who benefited and saved so many people did not mean much. And comparing to him, my life was nothing too. So I thought that, no, I cannot continue to stay in the place where the human life can be just stopped like that, and nobody will even be interested to see what happened and what caused that death. So that was one of the reasons why 4 months later I left Russia. I left Russia in June 30th, 1992. and I came to United States. That's how.
It's very sad to hear, and actually, it really goes to what we were talking about, which is, having the freedom to come to the U.S. and to be able to innovate and start a new career in the United States. I've heard that you have, as a part of your training, you have some other interesting talents outside of gastroenterology.
Yeah. So the thing is that I am coming from a very poor family, and in Russia, everything was directed by the government. You cannot change where you live. For example, I could not move from Gorky to Moscow. Gorky is the city where I was born. And when I was finishing medical school, they assigned me to work in a very small place, which was not even part of, which was not even able to provide internship. That is how I end up in a huge hospital, because they sent me there for internship. But when I entered that hospital, they liked me, and so they offered me job, so I did not have to go to that small piece. But originally, I always thought that they will send me to a small place where I will be one or two physicians, and I need to have as many specialties as I can in order to survive and help in that places. So the system in Russia in medical school was different than United States. If you finish 3 first years in medical school, and if at that point you don't want to continue medical school to become a physician, then you can stop and you will get certificate as a nurse, and you continue to work as a nurse. If you finish all 6 years, then you will be working as a physician. And in Russia, therapeutic massage was a therapeutic procedure, and only a certified nurse could do that. So after I finished 3 years and then I was qualified to be a nurse, then I went for specialization in therapeutic massage. And I started to do therapeutic massage, and I even taught therapeutic massage for many, many years in that institution. And then in Russia, I was also, when I learned about therapeutic massage, I got fascinated with acupuncture. And in Russia, acupuncture can be only done by a physician. So acupuncture, physicians were specializing in acupuncture only in 5 cities in Russia. You can learn it. So there was a long waiting list. But luckily, one of the cities was my city and my hospital. So I started to do research in acupuncture. I started to learn it. And when I finished medical school, along with the diploma of the physician, they gave me diploma of acupuncture. And then when I was in the residency in surgical internship in that hospital, I was treating a lot of patients with acupuncture. For example, the bronchial asthma is very successfully treated by acupuncture. So the patients would be scheduled. I could not take more than 5, 6 patients at a time. So the patient will be scheduled to be admitted. When one patient is discharged, the new patient is coming. I treat them for 10 days with acupuncture, and then they off steroids, they off all the broncholytics, and they go to their places, and I will take care of the next one. So that was the next one. Then when I finished the medical school, then I specialized in chiropractic. It was also a physician's procedure. You have to be a doctor to do that. So I got specialization in all those procedures. But when I came to United States, obviously my business completely shrink to only one. I have only one patient, my wife, and she is the only one who benefit from all the other specialties which I have. Nobody else benefit from it.
Well, a man of many talents, and I think to close out, just thank you again for this extremely deeply insightful interview.
Wait a second, Philip.
Yeah.
You know my wife. You met my wife.
Yes, I did meet your wife. I met her at FJGES. Tell me about your wife.
Yeah, let me tell you, I cannot tell you, the whole interview will not be enough for me to describe my wife. It will take too long, and I'm not sure that your wife will allow you to spend that much time on Sunday to talk about my wife. But I have to tell you about my engagement.
Yes.
So I was not sure if she will accept my engagement, and so I wanted it to be a little more memorable. So I scheduled her for colonoscopy. And when I came to pick her up to deliver her for colonoscopy, she said, "Oh, I don't think I'm ready. You know, it did not work that well." I said, "No, we cannot cancel. Let's go." So we go there, and I prepare the engagement ring. And when she wakes up, and all the nurses were participating in this and so forth, and then she wakes up and she see that something is on her finger, and I told her I propose it. I have all the nurses saying that yes, you have to. And she looked at it. She said yes, but she also said, "I am glad that he did not shove the diamond up my ass." When she saw it on her finger, she said that I'm glad that he did not shove it the diamond up my ass. So it's one of a kind engagement, and I think that that is quite memorable too.
And now you have two beautiful children.
Yeah. Yeah, I have two children who none of them wants to be a physician. They saw my long hours. They saw how much time it takes and how much effort I put into it. And so they don't want it. My daughter for a long time was thinking that she will be a nurse, but lately she changed her mind. And my son is doing an engineering. He will be a computer science. He's doing it in Georgia Tech.
And neither of them have any idea how much harder it was in the Soviet Union.
None of them.
Oh, they have no idea.
They have everything. They have all the resources possible. They have no idea what it is.
So they will probably learn from watching this interview.
I hope to.
They'll probably learn about you and about things that they never knew about their dad.
Hopefully, yeah.
Well,
thank you very much.
No
Philip.
problem. To kind of close out, I do want to ask you one last thing, and that is, what advice do you have for future generations who want to walk the same path as you? I mean, I personally have learned tremendously from you over the years, and I want to take this moment to thank you for your mentorship over the years as well.
Thank you. I thank you very much. I did not think that I had any impact on you or any other people. I just do my life. But I think you raised a very important question when you mentioned the mentor. It is extremely important to have a good mentor in the beginning of your career. It's important. And one of the examples, probably the best example, will be Chris Thompson. So when he started his work, he had David Carlock. I did not have conversation with him about it. It's just my thinking, but I believe that what happened is that he was probably bouncing his ideas through David. David is very experienced person, and he would tell this will work, this will not work. And he directed Chris. I'm pretty sure that he had a role in Chris choosing the path of the bariatric endoscopy. David knew that it's unmet need, and he directed him very early in his career. And that is what, if it happened to everybody, then it will save a lot of time, a lot of effort. And the other thing is that be respectful about your time and your effort, and put it into the things which can be achievable. For example, I know that Watson and Crick, people who develop DNA, I know that Watson would choose the project which is possible to be done within 5 years. Project will require 20 years, probably not worth to spend your time and effort. So choose something which is achievable, and make sure that you have claim for intellectual property. Spend time to learn the laws and protect yourself. Don't throw your ideas around without some benefit for you. That is just not right.
Yeah, no, again, it's all very, very good advice. And again, thank you so much. It's truly been an honor and a privilege to be able to interview you for this project. We'll look forward to the next time I see you.
Thank you very much, Philip. I think that it's a very important project. Each of us accumulated some knowledge, and if we live with that knowledge, people will not benefit from it. Each time you talk to somebody else, I understand how much time it takes for you, how much effort you have to divert away from your family to do all this. But this will help people not to repeat my mistake, not to repeat mistake of other people, and to be more successful, and we all benefit from it. Thank you very much. Thank you.
Thank you, Sergey.